All right, let's jump right in. If you've ever found yourself scratching your head over the ICD-10 CM codes for alcohol-related disorders, you are definitely not alone. Today, we're going to break it all down and make sure you have the confidence to get it right every single time.
So this is the big one, isn't it? The question that always seems to come up. Now, older systems made you feel like you had to draw this hard line in the sand between abuse and dependence. But ICD-10 CM, well, it completely reframes the whole conversation. It's just not a simple choice between two separate things anymore.
And here it is, the key takeaway. In ICD-10, it is all about the spectrum. So instead of thinking about two separate buckets, I want you to picture a single road. Abuse might be at one end of that road and dependence is further down, but it's all part of the same journey. That's the spectrum model in a nutshell.
Okay, so let's really dig into this first big idea. One spectrum, not two. This isn't just some small update. It is a fundamental shift in how we think about these conditions in ICD-10-CM. And honestly, once you really get this concept, the entire F10 category of codes just starts to click.
So what does the spectrum look like in the real world? Well, it's a range that goes from mild all the way to severe. And here's the direct translation for us as coders. When a provider documents a mild disorder, you're going to be using the abuse codes. And for moderate or severe disorders, that's your cue to head over to the dependence codes. See, it's all part of the same scale. So now that we've got the big picture of the spectrum, let's zoom in a little and look at the two main coding paths you're going to be using, abuse and dependence. Let's put these two side by side. On the left, you've got F10.1 for alcohol abuse. This is for the mild end of that spectrum. Your key indicator here is recurring use, even when it's causing negative consequences. Now, on the right, F10.2 is for alcohol dependence. This is for the more moderate or severe cases, and here you're looking for clinical symptoms like tolerance, where the patient needs more alcohol to get the same effect. But here's the thing. Those base codes, F10.1 and F10.2, they're really just the beginning. To paint a truly accurate picture of what's going on with the patient, we have to add more detail, and we do that using the 5th and 6th characters of the code.
This is so important because this expansion is what lets the code tell a much more specific story about the patient's condition right now. Are they intoxicated? Are they experiencing withdrawal? Or are they perhaps in remission? The code tells us everything.
Just take a look at this table. It really lays it all out. Adding a suffix with a 2 in that 5th spot means with intoxication. A 3 tells us the patient is dealing with withdrawal. A 1 is for cases in remission, and a 0 means it's an uncomplicated case. Getting these little details right is absolutely crucial for capturing the patient's current status.
Okay, theory is great, but let's get into some practical, real-world situations. This next part is all about tackling those common coding challenges that can sometimes trip us up. Here's one you see all the time. A provider documents drunkenness. Seems pretty straightforward, right? But the correct code depends entirely on the context you find in the rest of the clinical notes.
Here's a clear guide for you. For simple, straightforward drunkenness, you're going to use the abuse code, F10.129. But if the documentation links that drunkenness to alcoholism, then it's acute drunkenness and alcoholism, and you need to use the dependence code, F10.229. And finally, for chronic drunkenness, you'll use F10.0. As you can see, the context is absolutely key.
Now, let's talk about a super important rule, and this comes straight from the official guidelines. The code for in remission, that's F10.21, has a really strict documentation requirement you need to know about, especially when you're dealing with dependence. And here's the crucial point. Nursing notes or any other documentation is not enough to assign this specific code. To use F10.21, the provider, the physician, or another qualified healthcare practitioner has to explicitly state it as their clinical judgment. This is a big one to remember. All right, we've covered a ton of ground, so let's wrap this all up with a final checklist of essential rules. Think of these as your go-to takeaways to make sure your coding is always on point. Rule number 1. If the blood alcohol level is documented anywhere in the record, you should add a supplementary code from the Y90 category. This just adds another important layer of clinical data. Rule number 2. What happens if the documentation just says alcohol use, but doesn't specify if it's abuse or dependence? Well, it's really important not to make assumptions. You're going to use the code F10.90 for unspecified alcohol use. And here's a common pitfall to avoid. If the diagnosis is toxic effect of alcohol, that is not a behavioral disorder, it's a poisoning. So it belongs in a completely different chapter of the codebook. You're going to look for T51.0.
And finally, rule number 4. Remember that a vague term like alcoholism isn't enough to pick a code by itself. It could mean abuse or it could mean dependence. You have to be a bit of a detective and look for those specific clinical indicators we talked about earlier to make the right choice.
And all this really brings us to our final and maybe most important question. How does being this precise with our coding actually impact patient care and public health? Well, every code tells a story, and getting it right ensures that story helps not just the individual patient, but also helps us understand health trends as a whole. Thanks so much for joining me for this explainer.